Okay, so Sanele is one of our own. He's a clinical associate who has specialized in public health and is now a lecturer in the clinical associate program. Okay. So he's been through this for the yeah, and I'm really glad to have you here and share your experience.
Good morning, everyone. Indeed, yes, my name is Sanele. You can call me Sanele or Sanele. It's up to you. You can choose. Yeah. So indeed, yes, I'm a clinical associate. I qualified in 2011. So before I start, I just want to share with you a very interesting story of how it all started here at University of Pretoria. So long time ago, it was in 2008 when when I was still working in KZN. In one of the clinics, I was working as a data capturer. So one day I received a call from the Department of Health. They said, you have qualified to do a course at University of Pretoria. So immediately when I had a wait in University of Pretoria, and I said, oh, maybe the dreams are coming true. Then, but I asked what course, and then they said, you are going to be doing a clinical associate course. I said, what is that? That we also don't know. A lady was calling us from the Department of Health in KZN. So, and then she said, but it's related to health. So because I was working in health already, I was interested. And I said, no, I will come. So the following day, we had to travel from KZN to Pretoria. When we arrived in Pretoria, we were the first students to do this particular profession. No one knew about this profession. Everyone was confused. Even those who were teaching us, they didn't know what they were supposed to do. So it was a bit of something. They were very complicated. So, but we had to struggle and go through it. And then finally, in 2008, in fact, we started in 2008 in September, not even in January, but in September. And then, but in our academic report, it's recorded that we only started in 2009 somehow. I don't know how. So, but then we started then as clinical associates. So one thing that we learned through this profession was that because no one knew about our profession, we had to learn about it and we had to understand it in a better way that anyone else could understand it. And fortunately enough for us today, we do understand it, and that is why we are going to be sharing today with you what is this clinical associate that everyone is talking about now. But then before I start talking about the clinical associate, I saw this slide and I thought this picture is very interesting. And I think that for everything that I'll be talking about today, I want to relate to this. What is happening here? As you can see now, as you can see now here, the global workforce. You see that in Africa, we were having the lowest global workforce. But then if you look in the side, if you look at the burden of diseases, we are ranked as one of the highest in if you're looking at the burden of diseases. So what is happening? So here in South Africa today, we are having about 6.4 million people who are HIV positive. Today, we are having a diabetes prevalence increasing, hypertension increasing. Today, we are thinking about saying that everyone who's HIV positive should be started on ARVs. But now, unfortunately, we don't see the number of healthcare workers increasing to the same level that the burden of disease is increasing. So, what are the solutions? And then most of this, and please don't only look at this and see it according to the continents or to the regions. Think about those people who are suffering. Think about those people who are facing poverty. Think about those people who are in rural areas. The people who some of them who wait more than 8 hours to see doctors. Some of them wait more than a day, more than 5 days, more than a week to be able to be seen by healthcare workers. Think about people who are still struggling even to buy something to eat, and yet at some point they are expected to have something to pay for the healthcare service. So this profession of ours is rooted in trying to make sure that we provide services for those who are disadvantaged, especially for those who are in rural areas. So because if you look at people who are facing poverty, They are the ones who are also facing the high burden of diseases. If you look at the HIV equivalent, it is about about 80% of South Africans who are HIV positive are Africans, and those are the people who are mostly facing the burden of high diseases. And if you look at the numbers or maybe if you look at the workforce helping those people in a way that most of them are in rural areas, in a way that most of them are in townships, in a way that most of them are going cannot afford to pay for medical aid. You can see that even though they're facing high burden of diseases, but still they don't have access to adequate health services. So now one of the things that I learned throughout my journey in these studies of public health was that it should not only about improving our lives, it should not only be about improving our maybe our academic careers, but it should be about the people, those who cannot afford this healthcare service. It should be about us trying to come together and improving the healthcare of our people. So now, so back this thing in fact didn't start in 2004. The training started in sorry, it didn't start in 2008, but the training started in 2008, but then the discussion started a long time ago. It was in 2004, and by that time I was still in grade 10 in 2004 when those discussions started. So now, in, when we were facing so many challenges in health services, especially the burden of diseases such as HIV and AIDS, TB, and many others, and then the workforce, like I was sharing. So we looked and we thought, how can we make sure that we improve the lives of people, especially in health? And then one of the solutions was to say, let us look at the clinical associate profession. And then when we were looking at and when those particular people were looking at this, it wasn't like they just woke up and said, let us start a clinical associate profession. It was existing already. It was there somewhere else in the world. It was there already in USA. It was there already in India, in China, in Malawi, in Tanzania, and in many other countries. So then a task team was started, and then they went to those different countries and they looked at how this profession was being started. And then one of the other things that I want to stress before I even continue is that even countries like USA, they have a clinical associate profession. So this shows that even though they are having so many jobs, there's still a need of having clinical associates. Hence, they are having a clinical associates there, and they are called physician assistant. So in 2004, then a task team was formed, and by that time, the Minister of Health was Honorable Manto Shabalala Msimang, and then she was so passionate about this profession. She loved this profession. She was very close to this profession. And one of the things that made her to be this attached to this profession was that she also had a personal relationship with this profession in a way that she had a daughter who was a clinical associate, but then she was in USA, and she's now with us here at University of Pretoria. Today I'm working with her. So the honorable minister was so passionate about this profession. She then started the national task team, and then there were meetings. But then one of the things that was happening that there was so much negativity. There were so many people trying to block this to say no, let us train more doctors, and others saying, do we really need clinical associates? And there were so many questions. But then because of those few people, like Professor Hugo was also there, they were so passionate about this profession. They said we should start this profession, and then we ended up starting it. And then in 2008, like I was saying, I was in the first group. So now, what's the clinical associates? The clinical associates are competent professional members of the healthcare team. Like everyone else, like nurses, like doctors were also part of the team. And we are having one mandate, as everyone else in the health service, is to improve the lives of people. And for us, we were so passionate about saying that let us help these people, especially those who are poor. Let us help, especially those who are in rural areas, those who cannot afford to go to private, those who cannot afford to pay for better healthcare. And then they are trained. In fact, here, I should be saying we are trained. Those are also one clinical associate. we were having knowledge and skills to make sure that we do have our people, which is patients in this regard. And then most of the clinical assistants are after qualifying, they work in district health systems in South Africa. And then we are registered with HPCSA, Medical and Dental Board. And then I thought maybe it would be interesting to also share with you how do we recruit, how do we go about recruiting clinical assistants. So now, like all the other courses, we are having our own requirements. So you obviously you must have matric, otherwise then if you don't have matric, then how you go to pass your if I don't think you will be able to make it. So you must have a national standard certificate, and then you must have English, Maths, and Life Science. They must all be level 4. And then particularly in University of Pretoria, we have private students, and then we have a Department of Health, and then we have others, maybe by NFSAS and maybe by others. So about 20% of our students, they are private in a way that they are paying for themselves. And then we also have about 70% of our students are bursary holders. They are coming from they are paid by the Department of Health. And then now, what is interesting about the bursary is that what do we do? So we look and we say if or maybe we say in the past people were going to medical school. But those who are coming from Sentin, or those who are coming from Victoria Central, or those who are coming from maybe Mshanga. But now, we then expected people from Sentin, and even the way they say, I'm from Sentin, we expected those people then to go and serve people in rural areas. Sometimes it's almost impossible because those people they have never been in rural areas. They have never stayed there. They don't understand what is happening there. They don't understand the culture. They don't understand the environment. Some of them don't even understand the language of those people. So we have to have a doctor, and then we also have to have another person there translating to that particular doctor. So it make our work even to be more difficult. So now we said when we were starting the program, maybe let us look then at the ways of saying of increasing or making the retention to be better. And how do you do that? So we said let us go to rural areas and then let us recruit. And by recruiting from rural areas, we are not only solving the solution of saying that we are going to be having people who are coming from these areas. We are taking people who are disadvantaged, who are from disadvantaged families. People, so we are fixing the health system. We are fixing the poverty issue. So it is helping the nation in many different ways. So there are so many advantages of this profession. So we go to rural areas. We take people who grew up there, who know. People there are struggling. People there need clinical assistance. People there need health services. People then are waiting on the queues for almost the whole day without being able to see the doctors. And then, if you ask them, are you going to go back to work in rural areas? Most of them, yes, obviously, yes. I'm from there. I want to go and serve my community. Yeah. And then others are sponsored by NFSAS or maybe by other different ways. Okay, so now our training, in fact, our degree is called a Bachelor of Clinical Medical Practice. And then it is a 3-year degree. So what do we do? So in clinical associate, we believe that we learn more by actually doing. Even though we believe that we learn more by actually doing, but we still believe that there is still a need for a theoretical knowledge. Otherwise, then you can't just take anyone and then go and put them in the hospital and say you learn by doing practical. So what do we do? So in the first year of training, we have clinical assistants coming to the university here in the medical campus, and then they spend the first 6 months here in the campus, and then they do modules such as physiology, human physiology, they do pathophysiology, they do anatomy, they do introduction to pharmacology, they do, and then we introduce them to physical examinations and history. And then in 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 the second and in the third year of training, we then say let us take them to where they are going to be working, because we want them to still continue being attached to the people that they will be serving. So if you go and you train someone in Steve Biko Academic Hospital, but then after 2 years, then you expect them to go and work in rural areas, it will be a problem. So we recruit from rural areas. They come to university for 6 months to a year, and then we say, they land there. Then we send them back to rural areas to go and to practice there, to learn there, and to be practical. But then when we're doing that, we have what we call clinical learning centers. In here at University of Pretoria, we have about, I think, about 22 clinical learning centers. What do we mean by that? So in each of the hospitals that we're training at, we're having a family physician, and then we're having nurses who are responsible we're having a doctor called a family physician, we're having nurses who are involved in the training, and then we're having even other allied healthcare workers forming a team to say we are responsible for training these particular clinical associates there for the duration of the period that they will be in those particular hospitals. So we train here in Gauteng, in Mpumalanga, in KZN, and this year we started even training in Limpopo. And I'm so happy that today in this class we also have clinical associates. We show that this profession is growing. And then I think it will also be important for us maybe to understand what do they do, because we always have this question with it. I mean, these clinical associates, what are they really doing? And then people we should ask, are they doctors? Are they? And there's a story that I didn't tell you. You know, when I qualified in 2012, for the first month I went to work in KZN, and then I came to the 2nd of January. I was placed there. And this is another good thing about clinical associate profession, that immediately after you have qualified, for especially for those who are having bursaries, then the Department of Health will then place you to go and start working, to go and start helping out people. So when I arrived, and I still remember I had my blanket with me, and few of my other luggages. And then I arrived, and then I was told to go to the office of the CEO. And I said, okay, my name is Sanele Ngcobo. I'm a clinical associate. I was told that I should come and start working here. And then a CEO asked me, oh, okay, so you are a doctor? I said, no, I'm not a doctor. He said, oh, you are a nurse? No, I said, no, I'm not a nurse. And then she said, are you? So then, what are you? I said, I'm a clinical associate. And she said, no, okay, you mean a staff nurse? I said, no, I am a clinical associate. And then she was confused. But then in that process, one of the things that I learned to understand is that the best way to show people what is a clinical associate is by working together with them. And for them to understand, the more you work with them, the more they start understanding. We really need this clinical associate. You know, we were having many clinical associates in the country. Today we're having about 550 clinical associates all over the country. So they're trained at University of Pretoria, at VET, and also currently it's only those 3 universities. But we're also pushing for our universities to say, if this is really a solution for the challenges that are being faced today, then everyone should be training. All the medical schools should be training a clinical associate. And now I've forgotten what I wanted to say. So, and then the best way to show what is a clinical associate is by working with the people, by working with the doctors, and by working together with the nurses, and they will get to understand. Because now, what I saw, if you take a clinical associate and then you go and you place them in hospitals where you have about 60 doctors, and then you expect them to be appreciated, sometimes it becomes difficult. So usually take them and put them where there is a need. Take them and put them where there are no doctors, where or maybe where there are 3, 5, or 6 or 7 doctors. They will get to be appreciated there because if you take them and put them in big of a shortage there, maybe yes, but then comparing with Malanga in Ntwalo Hospital, where we only have about 10 doctors, serving a very big population, there where there is a need, people will start appreciating the clinical associate. So obviously, when you start, your first few days will be very miserable because people want to know. They will think, this one is here to take my job. This one is here to do this. And the more then you work practically with them, the more they see with I think this from now on, I don't have to do this. This the clinical associate is taking care of this. Then a doctor now spend more time with complicated cases, and then they start appreciating this profession, which is a profession that is going to help our country to to try and deal with the challenges that who are facing today. So now the scope of practice is very important, and I need to also say this. We had struggled a lot with this document, which is a scope of practice. The scope of practice is supposed to be guiding us to say, you must do this, you can't do this, that you can do, that you can't do. But now, unfortunately, when we qualified, we were told that we didn't have a scope of practice, which was very difficult for us then because everyone, if you go there, then they say, okay, Baba, show me your job description, show me your scope of practice. What is it that you can do? Because most people didn't know, and you can't blame them because they don't know what is a clinical assessment. They need to be told. So it's only a document, a written document, black and white, that can tell what they can do this, they can't do this. Né? So we struggled then. Up until today, we still don't have a signed clinical assessment. Even though we now at least we have a draft that is about to be signed. Maybe it will be signed even before the end of this year. So we are advocating for that. So what is it that we can do? So we train clinical assessors to be able to obtain history, to take history, to do physical examinations, and then to also order and perform the diagnostic and the therapeutic procedures. And they also do a lot of investigative studies like X-rays, ordering of X-rays, performing ECGs, ordering stool tests, yeah, interpretation of those results, and then blood and many other things. I just took a snapshot from the scope of practice, which is still a draft now. So then they also have a right to develop and implement and monitor a comprehensive management plan for common and important conditions. So now this is very important because we say here in our training, it doesn't help for us to spend the the whole week teaching clinical associates about conditions that even most of the doctors have worked for maybe 40 years, but they've never seen those conditions. It doesn't help. We are saying let us focus on the common conditions that we are sure that almost on 90% of the cases we are going to be seeing those cases in and what are those cases? Commonly, the common cases. So your HIV, your TBs, your hypertensions, those common. There are many common conditions that we teach to we prepare them to be able to identify and to treat those particular conditions. And but then we say that then if you come with rare conditions, then you can always refer to doctors because our profession it is supervised profession in a way that we have to work with a supervising doctor. But then by saying it's a supervised profession, it doesn't mean that you have to have a clinical associate and a doctor here in one room. No, it doesn't work like that. So you can have a clinical associate working in a clinic and you can have a doctor working somewhere else, maybe in a hospital. Yeah? So when a clinical associate encounter challenges, then they can call a doctor and inquire and ask for assistance. So and then clinical associates can even prescribe medications, okay, according to the essential drug list and up to Schedule 5. And then they can also assist in surgery. They can make appropriate admissions, they can admit patients, they can discharge patients, they can refer patients. They can. So now, one of the other important things is that if you are a clinical associate, then you have to work or you have to have a very good understanding with the doctor that you are working with. Up to a level that that doctor understands that they can delegate this particular activity to you. So your scope is defined by your level of training. It is defined by a doctor that you are working with. If you are a doctor that you are working with is happy that you can do this particular procedure, so they can just dedicate you to say, please, can you do this particular procedure? Okay, so now I also wanted to touch on few studies that have been done around clinical assessment, just to show that we are not just talking it, but there is an evidence to say that this clinical assessment profession is indeed helping, and maybe it is one of the biggest solutions in our current challenges, especially in human resources for health. So there is a study that was done to check the cost effectiveness of clinical assessment and in putting them together with medical professionals. So yeah, we are focusing more on cost and effect. So training clinical assistants and employing clinical assistants, we're looking at how much does it cost to train a clinical assistant, and then how much does it cost to employ a clinical assistant. So what is our vision here? Our vision is to say we need to have a clinical associate. We need maybe to have two clinical assistants, maybe working with one doctor, or maybe four clinical assistants working with one doctor. And we want to say, in doing that, we don't want to compromise the quality. The quality shall remain the same, but then more people shall be saved, and we should save in doing that. So now we don't look how much does it cost to train a clinical assistant. First, it's a lot. It's still a lot because we are spending about 119,000. Second year is about 84,000. Third year is about 96,000. But then when you look at the total, it's about 300,000 for clinical assistant. And then you look for medical students. It costs about it's approaching $1 million now. Can you see? To train doctors. And rightfully so, it is a good thing because we still want doctors. We still need those people who go to university for 7 years or for 6 years, and they have this knowledge to come and help our people. But now here we are saying, let us take clinical assistants and let us take doctors, let us put them together, let us help our people. That is our main mission, to make sure that we improve the quality of health, and we make sure that our people, especially those who are disadvantaged, they can go to clinics and get the quality healthcare. So now, like I was saying, our scope of practice, clinical assistant can perform any act delegated by the supervising medical practitioner in accordance with education, training, and experience of the clinical associate. And then, now about the quality. If we are teaching clinical associates to say they must do, or maybe like let me just make an example with a drip. If we was saying we are teaching a clinical associate to put up a drip, an IV line, it should be at the same level that a doctor can be able to put up an IV line. Otherwise, then we'll be playing with our people if we say this one won't be able to put up an IV line at the same quality. So the quality should remain the same. If you are doing a procedure, there shouldn't be a difference. It should be the same. And then retention. And I'm going to be talking about retention just now. Okay. So there was a study that was done. Once again, it's also part of this one. To say, let us look now. Out of the doctors that we are training, or out of the medical students that we do have. In this case, it was about 984 medical students in 2011. Let us look how many of them are, are, are willing or are preferring to go and work in rural areas. So for medical students, it was about 5% of them who were saying, yes, I can go and work in rural areas. I can go and help our people in rural areas. And for clinical associates, it was almost 55% of them who were saying, yes, we are willing to go and work in rural areas. We do want to go back home and assist our people who are struggling there. And like I said initially, you cannot blame the medical student for saying, I don't want to go and work in rural areas. Because most of them have never been exposed to rural areas. So it will be almost impossible for them to go and stay and spend almost their whole life working in rural areas. So now, with us now saying we recruit from rural areas, we have seen that it is helping us. Indeed, it is helping us because now we're having about 55% saying we are willing to go and help where there is really a need. And then now we said let us say maybe we're having a budget of about 10 million and we want to use this budget. What can we do with this budget? We have two options. It's either we just train doctors, or maybe we train or we have doctors and clinical assistants working together. Then now we want to see how will this work. So the first part is to say, okay, let us just have doctors. And then the second part is to say, let us have clinical assistants and doctors working together and see how would that help. Okay. So now, what will happen is that okay. So now, here in this case, you are saying let us just train 18 doctors, and then in this case, you are saying let us just train 7 clinical associates in 15. Sorry, 7 doctors and 15 clinical associates. So now, if a clinical associate can free up to 50% of the doctor's time, you can be saving in that scenario. You can be saving up to 18.7% of that budget. So you'll be saving from that 10 million rand. You will be saving 18.7% of that whole budget of 10 million. Because now you are having doctors working together with clinical associates, and you have more staff there now. In a way that you will be having about 21 clinicians, but then yet they are still giving you that quality of health, and yet you are still saving. There's still the money that is remaining. So a training of clinical associates is in such a way that after you have qualified, if you see a patient with TB today, and maybe there's something that you don't understand, you go and you ask to a doctor to say, please assist me here. And then a doctor tells you, oh, in this case, you must do this. If you have been doing the same thing for over 5 years, by the time you are the practicing for the 5th year, almost all of those cases, you wouldn't need to go up and ask a doctor, because you would have been doing that for many years. So with experience, some clinical associates can free up to 80%. They can free up to 80% of the time of the doctors. Sorry, technology sometimes can play with you, eh? Even when you think you know it, sometimes. Okay, so with experience, clinical associates can free up to 80% of the doctor's duties, and by that you are saving almost 84.4%. What you do with that 84.4%? Take it and put it back. Train more, employ more, employ other doctors, employ other clinical associates. So in this way, we will have more clinicians helping our people and our people will be rejoicing and they will be having a better quality healthcare. That is our mission. Today we are sitting here because we want to make sure that we improve the quality of health. Okay, so then another case that I also wanted us to look at is to say now, and in particular in this case, I was doing this for my MPH to say now, let us look at one of the procedures because we are saying that clinical associates should be doing this and this sort of procedure. And then in this case, we zoomed into medical circumcision. We say, let us look, is there a difference in doing this procedure? Is there a difference between a doctor and a clinical associate? Wanted to know. Because one of the things that we don't want to do, we don't want to compromise the quality of healthcare that we give to our people. We don't want to say because we are struggling, then we must have a person who is not competent enough to be able to do a medical circumcision. If we give a clinical assistant a duty to do a particular procedure, it should be at a same level that a doctor should be doing. Otherwise, then we're compromising the quality. Otherwise, then we're undermining the people that we're saving. Otherwise, then we don't respect those particular people that we're saving. Otherwise, then we're saying that those people who are disadvantaged deserve less quality health service. And we don't want to do that. Hence, we are saying the quality should remain the same, even though we're still having a profession of clinical associate. So, in this particular study, we're comparing circumcisions that were done by doctors and from those that were done by clinical associates to look at the quality and say, is there a significant difference between those two? As we know that today we have about 6.4 million people who are HIV positive. We have about around 3.2 million people who are on ARVs, and we are soon saying everyone who's HIV positive should be started on ARVs. Unfortunately, today we are having almost 1,000 young people getting infected with HIV and AIDS on daily basis. So each and every day we have about 1,000 young people getting infected with HIV and AIDS. So HIV and AIDS is one of the biggest challenges that we are facing in our country. In 2010, I think about 200 and sorry, in 2010 it was about 200 and something thousand people who died of HIV and AIDS related conditions. And then when you calculate that, when you go down and deeply down and you look at it, you could see that in every 2 minutes, at least one person was dying of HIV and AIDS. And you see, that is a main problem. That thing shouldn't be happening. And yet, we we are afraid of Ebola more than we are afraid of HIV and AIDS. And you ask yourself, why is it that we are so scared of conditions that we have even never seen even one person who died of a condition here in South Africa? Then a condition that kills at least one person in every 2 minutes, a condition that each and every day will infect about 1,000 people. You know, over 2 years in the past challenge of Ebola, in the past 2 years, we had about 11,500 people who died of Ebola. About 11,500 people globally in the whole world. About 11,500 people died of Ebola. Then you come to South Africa and you think, how many people died of HIV? So, in less than 15 days, that same number of people who died of Ebola over 2 years globally. In South Africa, HIV would kill those people in less than 15 days. That same number of people would have died of HIV and AIDS in just less than 15 days. And it took Ebola more than 2 years to kill those same number of people globally. So, to some extent, I sometimes think that maybe we are starting to underestimate HIV and AIDS. So, in this study, we're saying, as we're pushing to say, let us circumcise more young people, let us have more young men being circumcised. In that process, we don't have, we don't compromise the quality. And unfortunately, initially, when this campaign started, clinical associates were not there. So, what had to happen was that we had to take these same doctors that people are complaining that in hospitals there's a shortage of doctors. So we had to take the same doctors and say they must go and circumcise young people. So now we are solving another problem, but with another problem. Because now in hospital people will be complaining that now we don't have doctors. So and then like one of my friends used to say that a global medical solution came, which is a clinical associate profession. That solution came, and then we had clinical associates. So, like I was saying, we were having a challenge with HIV and AIDS. So, our government said let us aim at circumcising about 80% of males, or from 15 to 49 years by 2016. In fact, now that is true, and I don't think we're going to reach that goal of saying 80% should be circumcised. That is why today many people, especially NGOs, they are running to make sure that they try and push and reach this target, which is 4.3 million people who need to be circumcised by now. Like I was saying, do we have enough doctors to be circumcising those 4.3 million people while we have others suffering in hospitals? I don't think we do. So clinical associates came in and then they had to. Oh, so by the way, these are our clinical associate students, and then I happen to be also visiting there and wearing the So this is a picture, and every time when I see this picture, I smile because I think that the future of our country is bright when you look at these young people. Let me tell you, the majority of clinical associates today, of clinical associate students today, even of clinical associates, they're still very young. Majority of them are about 25, 26, 27. Yeah. So you have these young, passionate people coming in to be part of this system. And one of the things that I enjoy more about this is that, fortunately for me, I do encounter young people coming in January. I have a responsibility of making sure that they all arrive from all different provinces. So sometimes I do collect them from the station to place them in their residences. So in that process, I, I usually interview them. I usually speak with them to understand the background. And majority of them, they're struggling. They're coming from highly disadvantaged families. Majority of them, they've never even seen this beautiful lights of Pretoria and all these kind of things. And one of the things that we always try to do is to say, let us not lose them in the process to say, now they come, they see Pretoria. Pretoria is very beautiful. You see this light, even at night, is still like during the day. So we always try to make sure let them not lose that thing to say, we want to help the people. We want to improve the health system in our country. We want to make sure that we go back to where we're coming from and help our people. So the future. So this is the future. It's about clinical system. Now, so in the study that I was doing, we went to different hospitals here in Tshwane district, and then we were reviewing the files of the circumcision. So it was a retrospective course study where we're comparing doctors and clinical associates. So we reviewed, in fact, we reviewed about 5,000 files of, of people who were circumcised, of males who were circumcised, and then we analyzed that data. So this is one of the clinical associates doing a circumcision. As you can see there, I was just working with this guy on Saturday doing the same procedure. And you can see there, down there, those are there, he's about to cut. He's about to cut the first thing. Okay, so now what were the results? So here in Tshwane, out of those 5,000 files that were reviewed, we saw that 86% of those they were done by clinical associates. So here in Tshwane, 86%. In fact, I've added more of the files. So now it's about 87% of those were done by clinical associates. And then doctors doing about 13% of those. And you can see now the scenario that I was talking about initially to say, let us have maybe 4 clinical associates, 5 clinical associates, and maybe we have 1 doctor. They work together and then they produce results. The quality remains the same. A doctor who's there will be going around making sure that the quality still remains the same. If there's a problem, a doctor should always be there to make sure that they assist. Okay, now we looked at the duration. How long does it take for a clinical associate to do circumcision? So for clinical associate, it takes about 14.63 minutes to do circumcision. And then for doctors, it's about 15.25 minutes. Why is that? There are so many reasons behind this. One of those reasons is that for some of clinical associates, they are doing that almost on daily basis. So the more you do it, if you are going to be doing a procedure for maybe if you're going to be circumcising maybe more than 100 or maybe more than 1,000 patients, and then you come and you work a doctor who have maybe done maybe only 50 circumcisions. Through your experience, not only your level of training, but through your experience, you will be quicker and you will be faster than this particular individual. But some of the reason might be that sometimes if there is a complicated case, sometimes they are sometimes referred to doctors. And then it might take a complicated case more to do compared to another case. And then we also looked that for those who are having phimosis, they're mostly done by doctors. Like I was saying, if there are any complications, usually those will be referred to doctors, which might be the answer to why then it can take longer for doctors to do these particular procedures. And then, as you can see, fortunately for those that who were circumcising, in fact, not fortunately, it's still unfortunately, that about 2.40 were HIV positive, and then for doctors it's about 1.5, so HIV positive. So another thing that we also want to say, or maybe before I forget, by saying let us circumcise young males, or maybe let us circumcise the males. What we have seen more males coming to the health facilities, way beyond what we have seen in the past. Because in the past it was very difficult to ask and to convince males to come and do the HIV testing and testing. But today, through the MMC, we are seeing most of them coming to say, let me test. And it's been a very good experience for us clinical officers to be involved in doing that. So now, we look at the complications. And I want to say this again. When we are saying clinical associate must be doing this kind of procedure, we don't want to compromise the quality. So the quality shall remain the same. It is very important. We don't want to undermine our people. So, as you can see there, swelling. In fact, this is supposed to be swelling. And you compare that. So for clinical associate, it was about 35.09%. So this is after the circumcision has been done, and then they come back for follow up, because I think this was about 3 days after the circumcision. So most of them usually they would have a swelling, but then we have to compare. Is it not different? So 35% for clinical associate, and then 34%. So it is almost the same. And then the pain after the procedure. So 1.73% and then 2.21% for doctors. Almost the same. The bleeding, and this was very interesting. The bleeding for for clinical associates, it was 0.62%, and then this side it was 2.12%. This might speak to say we are having clinical associates who work full time doing MMCs. So they are daily work. So they wake up in the morning, they go, they cut, they come back again tomorrow, they do the same thing. So if you do that same thing over a period of maybe a year, or then you are going to be an expert in doing that. And then we also looked at the rate of infection. It was almost the same. For clinical associates, 0.48%, for doctors, 0.30%. And then wound destruction for doctors, for clinical associates, it was 0.29%, and then none for doctors. So wound destruction is that after we have circumcised them, and then we have sutured. Does the wound open up? Maybe they come for follow up, and then the wound is open like that. So this is what we were looking here. And yeah, with clinical assessment, it was, as you can see, this is 6 out of about 4 out of about 2,500 people. So it's still almost the same. So yeah, we concluded that the clinical assessment are playing a better role in MMC. And then the last study that we also looked at, and there are still many of these kind of studies that need to be done. To say, let us see how can we improve the quality of health, and how can we utilize clinical assessment. Earlier this morning on Power FM, there was a discussion that we have doctors working about 30 hours a day or in 2 days. Continuously, they work about 30 hours. So you work the first 24 hours, then you continue again. And what is the reason for that? And there is a petition that is going around. Doctors are advocating for people to sign a petition to say we cannot be expecting doctors to be working in such a long period of time, 80 hours continuously without resting. What are we really saying? What are we saying about the quality? Unfortunately, I think it was last week where we had one doctor who died after he was working, and he worked about 30 hours continuously. And then on his way to home, he was involved in an MTA. So some were saying this might have been related. This fatigue might have been one of the reasons. And we want to deal away with those kinds of things. So we need them to come together and find solutions. So with particular procedures, like for example, in this one, I was looking at the spinal anesthesia to say, are clinical associates doing spinal anesthesia? And we saw from the result that yes, they are doing spinal anesthesia. So now, from now on going forward, we need to be looking at those kind of procedures to say, can they do this? Do they have adequate training? Are we not compromising the quality? Because one of the main things, like I have been stressing, the quality should not be compromised. So let me just go straight to our result. So about 79% of clinical associates, they said, yes, they have done spinal anesthesia before, but yet they indicated that they still need more training in doing spinal anesthesia. So if you look at those kind of procedures, spinal anesthesia, if you think of it, it's one of the complicated procedures. It's one of the high quality, or maybe one of the procedures that you can't just give anyone to do. So if already clinical assistants are doing these kinds of procedures, we really need to think of how do we make sure that we utilize them adequately so that they don't, so that they assist in mitigating the pressure. Okay, so like in this study, I was saying most clinical assistants are involved in doing the spinal anesthesia, and then we need to make sure that we review their curriculum so that we don't compromise the quality. But then, challenges. Hey, there are so many challenges, eh? Like, but what I usually say to people is that it took America for more than 40 years for them to have the scope of practice for physician assistant. Took so many years. But with us, we do understand that this is still a young profession, still a new profession. But unfortunately, their profession was introduced in 1960s. Now it's 2016. We don't have that enough time to keep on waiting for that longer period of time. We want challenges to be fixed today. And then, by the way, I'm also a part of an association called the Professional Association of Clinical Associates in South Africa. So what we did in 2012, immediately after we qualified, we came together here at University of Pretoria and then we said we have to speak for ourselves. We have to follow a full strategy. For us by us. If there's anyone who knows this profession better, it is us as clinical associates. If we have to voice our challenges, it needs to come from us as clinical associates. So we came together and then we formed an association. Today, one of the most powerful associations in South Africa, and I happen to be a secretary general of that particular association. And it is working, it is vocal. Anywhere you go, you will see. It's unfortunate that maybe some of you haven't came across it. But I'm promising you that you are going to come across it. Because we are not only advocating for clinical associates, but we're also advocating for the people. Because our main reason for us to be here in medical school is to improve the lives of our people. That is our main reason. These ones, the other ones, salary, they're also important. But our main priority is to make sure that we improve the quality. But then our lives also have to improve. Yeah? To say you go next to a hospital, you go and you work and you do those kind of procedures. Very complicated one. You even put up an ICD. But then you then discharge that patient. Then after, when you're going home, you sit in a taxi with that same patient. Not because you want to, because sometimes you can want to, but then because you cannot afford to to drive your own car, because you cannot afford to live a life that you deserve. So we were very careful about this to say a reason that we had this profession was to say, obviously, and we do agree with that, and we do want to say that in a current financial crisis in our country, it is important that we all come together and we become the part of the solution. But then that shall not say other people now are being I don't want to say undermined, but people should be earning a living salary. And one of the main reasons for, and this is serious, one of the main reasons for people to say we cannot continue staying here is because of the salary. So you work the whole day and then you get about 180 per annum, and you look at the level of the work that you do. You think is it fair? I don't think it's fair. But what is fair? Then we need to sit down and discuss that. So we don't want mid-level head workers to be taken advantage of, because you know I think you are from a disadvantaged family. Whether we took you, we gave you a bursary. No, that shouldn't happen. People shouldn't take advantage of income to say we assisted in the first place. But now we are working. We're changing the lives of people. And then discover practice, like I was saying, it has been a problem for many years. But now, as I was saying, we are having an association. And this association is very vocal. Before the end of this year, I'm telling you, I can come back here and tell you that we are having this